We'll have questions for this session, and that's the fun part for us. So, my name is Dr. Nancy Albert. I'm from Cleveland Clinic, and I'm very happy to be chairing the session titled Maintaining Renin-Angiotensin-Aldosterone System Inhibition in Managing Hyperkalemia, Expert Insights into Best Heart Failure Patient Care. I'm thrilled to be joined today by Dr. Stephen Green. You may have just heard him speak a few minutes ago. He is Associate Professor of Medicine at Duke University School of Medicine and Duke Clinical Research Institute, and Dr. Stephanie Barnes, a Clinical Director of Advanced Heart Failure from Duke University Health System. So I'm going to go over a few notes just to get us started up front. The first one is I'd really like to thank AstraZeneca Pharmaceuticals for providing an educational grant for this symposia presentation. Program management services are provided by Vox Media. The symposium is sponsored by the AAHFN. And if you'll take a moment right now, there's somebody coming around with a brief questionnaire that's been distributed. Staff will be collecting the questionnaires as we begin the program. So if you can complete that, it gives us an idea of what's going on in terms of your thoughts about this topic. Attendees may earn continuing education credit by attending the session, and when you complete your evaluation of the AAHFN annual meeting sessions, it'll be on there. Please see the faculty disclosure information in the handout if you're interested in each of our speaker disclosures, and we will be asking you to complete an evaluation of the symposium in the handout as well, so you should have gotten a handout from that purpose. Representative slides are included in your handout, and they're also available on the AAHFN app, and presentations may be viewed later on Medscape. So you'll see somebody walking around with question cards. We know some of you may be shy about going to the podium microphones and asking your questions, but your questions are really important to us. So personnel will collect those cards throughout the program, and I'll receive them up front and be able to ask our esteemed co-presenters questions. And then finally, please silence your electronic devices if you've got them available. So to give you an idea of what's being planned here, I'm going to be giving the first presentation on hyperkalemia, a barrier to optimization in heart failure treatment. Then we'll have Dr. Stephen Green come up and talk about overcoming the barrier of hyperkalemia, treatment with potassium binders, and maintaining RAAS inhibitor therapy in patients with heart failure. And then finally, Dr. Stephanie Barnes is going to be giving us a case presentation of patients managed with elevated potassium. So let me go ahead and get started over here. And so again, my topic is a barrier to optimization. You could see my disclosures. And so when we think of hyperkalemia and the alarm in heart failure, just keep in mind that it's technically defined as a potassium above 5.0, but oftentimes we don't get really nervous about it until it gets a little higher. Usually by 5.5, we're starting really to pay attention to it. It disrupts cellular electrical activity, especially in the heart, and it can impair conduction and excitability. And so it can be a potentially life-threatening electrolyte imbalance and lead to arrhythmias. And again, when we think about its occurrence, in the general population, it's about 1 to 10% of all hospitalized patients. But sadly, in our patients with heart failure, in adults with heart failure, it's 2 to 3 times higher. And if you look at this little slide here and you look in the green, clinical trial data, in clinical trial data, about 11.8% of patients will develop hyperkalemia, and they use a K of greater than 5.5 in this example. But if you look at observational data, real-life data, if you look at the bottom, you could see these are newly diagnosed patients, and then it's about 0.9% of the patients may early on have hyperkalemia. If you look at the middle dot, 26% of patients will have hyperkalemia with a mean follow-up of 6 years. And again, that's with a K of 5.5. The very top dot is 39% of patients will have a potassium of 5 or greater milliequivalents per liter at 2.2 years. So it's likely about 40% of our patients may have hyperkalemia if you look at 5.0 as the beginning marker of it early on. And so if we look at the economic burden and why this is such a big deal for us, if you look at index service date and hospitalization, look at 37.8%. But if they patients don't have hyperkalemia, only about 2.2%. If you look at being admitted to the ED, 9.5% have hyperkalemia versus 4% with no hyperkalemia. So again, these are patients that have more economic burden because of that. And if you look at the total costs over 30 days and over 1 year, you could see they're almost 8-fold higher when you have hyperkalemia, and almost double or a little more than double for 1 year. So inpatient costs are the primary driver and accounts for about 68% of our 1-year total medical cost difference between those with hyperkalemia and those without. So Dr. Paul Heidenreich just talked about a bunch of the costs of care, and hyperkalemia is one of our burdens that we have to deal with. So why do we see more hyperkalemia in patients with heart failure? Well, we know there's multiple culprits, some of which are medications, the RAAS inhibitors, ARBs, and mineralocorticoid receptor antagonists, especially the steroidal drugs, the eplerenone and spironolactone. But if you look at the circles on the slide, you could also see diabetes, kidney disease, and previous history of hyperkalemia, maybe because you had other patient characteristics. You're somebody who just loves to eat foods that are very high in potassium every day, multiple times. And so when we look at the limitations of treating hyperkalemia currently, there's 4 big groups. One are low potassium diets. Well, we want our patients to eat healthy, and a lot of fruits and vegetables are those foods that are high in potassium. So asking patients not to eat potassium-rich foods can really ruin their diet and push them toward the foods that are higher in sodium that we want them to stay away from. So that's a big problem. It literally contradicts the DASH diet and also the Mediterranean diet, and it could lead to worsening hypertension if they're eating the wrong foods. You can see with loop diuretics, when patients are on loop diuretics, of course, they lose a little bit more potassium, but when we have patients that are not on loop diuretics, because we're taking good care of them overall, they're not getting rid of as much potassium. But for patients on loop diuretics, we don't want to use that as a treatment for hyperkalemia because it could lead to hypovolemia, worsening renal function, it could lead to dizziness, and somebody doesn't understand it's because somebody was taking an extra dose of loop diuretic, and they may take patients off a life-saving therapy. We could decrease the RAASi therapies that we just talked about are life-saving and important to decrease hospitalization and mortality. It should be nobody's first step, although time and time again we see that being the first step when our patients have hyperkalemia. And then, of course, we've got the old-fashioned K-oxalate or sodium polyestrine sulfonate that has a lot of side effects, and so it's very tough to use. I'm an old ICU nurse, and we didn't even like using it on our patients who didn't have to take it in orally. We'd put it down a nasogastric tube. It's just a tough drug to deal with. Not just the unpleasant taste, but it could lead to intestinal necrosis, et cetera. When we think of potassium, we need to remember that 90% of potassium is excreted renally. Only 10% is excreted through the GI. And so our patients that have chronic kidney disease are more likely to get in trouble. You've been hearing a lot about cardiovascular chronic kidney disease and metabolic syndrome, KCM, and we're going to be seeing more of that as we have to deal with this new phenomena, not new for patients, but new for us to really pay attention to. Now, there are emergency therapies that we can use for hyperkalemia, and I'm not going to go over each of these, but again, this is for acute emergency treatment. We really need to consider how do we keep our patients on the right drugs day in and day out, not just in emergencies. And so what do we need to do to keep our patients on our RAASi therapies, inhibitor therapies? And these are not the answer. So we do need to consider down the road what is needed. So when we think of the limits of guideline-directed medication therapies with hyperkalemia, again, Having hyperkalemia limits achieving target doses because we may decrease the dose as a way to decrease the hyperkalemia. And we could see in up to 4.6% of patients on ACE inhibitors or ARBs, they've had their doses limited because of hyperkalemia. Up to 15% of patients on MRA end up having their doses limited. And again, look at for MRA especially, we see 33% of patients having their drug discontinued. And as we learn more and more about MRAs and about aldosterone, we need to understand the huge value it plays in heart failure and how important inhibiting it is in therapy for our patients. Guideline recommended monitoring of serum K should be at 1 week and then 4 weeks and every 6 months. And oftentimes we even have in the guidelines that if you can't monitor these patients because they're a no-show, they're not following through, maybe we should limit the use of MRA therapy. So part of it needs to be how do we get our patients to show up for blood testing, lab testing, so that we can make sure that we're being safe in using the right drugs on our patients. So if you look at this slide over here, this just shows clinical outcomes are worse after MRA discontinuation. And if you look at the slide on the left, by the way, the red is somebody continuing on MRA, the blue is somebody being discontinued. And on the left, you could see the risk of death, MI, stroke, or worsening heart failure. And there's a 10% increase in the risk of death, MI, and stroke after discontinuing life-saving therapies. And so we need to be very careful about that. On the right side, again, if you discontinue your MRA, that part of the slide is looking at the risk of recurrent hyperkalemia, and you'll see right away the red bar is up top now. There's a 25% reduction in the risk of recurrent hyperkalemia if you discontinue the drug. But that's not really our solution these days. We need to figure out how we're going to work around being able to continue our therapies for our patients. So here, when we look at down-titration or discontinuation of RAASi therapy, it's associated with a doubling of mortality. So you could see maintained at 13.7%, down-titrated, the mortality rate goes up to 27.7%, and discontinued, it doubles to 30.1%. That's not what we're aiming for our patients. Hyperkalemia is also a burden for us as providers. Would you guys all agree? It makes our life a little bit tough because we have to make changes in therapy, we have to explain to the patient what's going on, we've got to get timely lab work, we need to review that lab work. Again, home monitoring devices may help patients with adherence, but they're costly and they may not be easy for patients to use, especially the devices that require internet access, et cetera. Medication adjustments based on lab findings takes a lot of time and energy for us, and using pharmacists or APRNs works, but somebody's got to pay for their time and effort to do all of that to manage hyperkalemia. So if we think about prevention of chronic kidney disease, that can reduce the risk of hyperkalemia as well. And so we need to identify our patients early on who are having an increased risk of chronic kidney disease. First of all, we could look at the risk factors for chronic kidney disease, and you see a bunch of them sitting here: obesity, smoking, type 2 diabetes, hypertension, even having low physical activity levels is in the literature as one of the social determinants of health. And then, of course, using our life-saving therapies can also worsen our eGFR, at least initially. So when we think about preventing CKD to decrease the risk of hyperkalemia, access to early CKD treatment is really important. Getting an estimated glomerular filtration rate and getting a urine creatinine to albumin ratio can really let us understand how bad our kidney disease is and what the next steps are in terms of the treatment for them. When we think of CKD prevention, I don't know how many of you attended our one of the dinner symposiums last night, but we had a beautiful slide showing what happens when you get the right drug on, a sodium glucose cotransporter 2 inhibitor, and how it really prevents or reduces the progression of CKD compared to patients who are not on the drug. So even though you get a little dip initially in your eGFR, in the long haul you see benefit, and we need to remind people of that. So there's also a lower risk of hyperkalemia because SGLT2 inhibitors help a little bit with diuresis. They're not meant to be a diuretic per se, but they do increase urine output, especially in the first few weeks after they're started. And that's especially true for patients with heart failure and type 2 diabetes. And then we need to remember we've got our GLP-1 receptor agonists, and they may provide renal protection and lower hyperkalemia as well, again, especially in patients with type 2 diabetes and CKD, and as we're learning more now, our patients with HFpEF who are obese. And newer literature is coming out in HFrEF with obesity as well and using the GLP-1 receptor agonists. So when we think of hyperkalemia treatment or management, think about all the people that need to be involved once somebody has hyperkalemia. Oftentimes the cardiologist refers to the nephrologist, and then the hospitalist comes along and changes things again, and we've got to get the pharmacist and the emergency department and everybody involved. So there are a lot of opportunities out there for many different transitions and many different groups. We need to enhance communication about potassium binders so that people understand we do have treatments that can work today. We need to document and share care plans so that people understand what the next step is when this occurs. We need to be advocates for our patient and try to explain to them why it's so important that we keep them on their life-saving therapy, even though it means we have to add a new therapy. And oftentimes people are like, really? I have to add another drug? But we need to explain the value of it. And I think, at least for my patients, when I do explain the value, they really listen, and they understand how much better they were feeling when we put them on these drugs, and we don't want to lose them. We don't want to take those drugs away. So you're going to see this slide, I think, in a minute from Dr. Stephen Green, but when potassium goes up, what do we do? And he is going to be answering that question for us. You can see a lot of things that are possibilities. I don't like the do nothing. I don't like the reducing ARNI. I don't like the discontinuing an MRA inhibitor. I don't like the reducing dietary potassium unless somebody's been eating 1 million bananas a day. Sometimes that works, right? But not always. So we could give it a good heave-ho, but if in 1 week we're not seeing any benefit, we need to really think about what the next steps are. So my key takeaways are that prevalence of hyperkalemia in adults with heart failure is 2 to 3 times higher than the general population. Hyperkalemia is an economic burden for patients and confers extra work in coordinated patient management. Traditional management options for hyperkalemia may not be well tolerated, or we end up decreasing evidence-based therapy, which we don't want to do. And dose reduction or discontinuation of RAASi and MRA is associated with worse outcomes in heart failure and can worsen chronic kidney disease as well, so we need to keep that in mind. So we need to be proactive in using and encouraging the use of contemporary potassium binders, whether it's by APRNs and pharmacists or providers. And again, we can't just think about them acutely, which is what most people have done in the past. We need to think about it from the long-term perspective. So with that, I'm going to stop and welcome Dr. Stephen Green to the stage to continue with the next section.
All right, well, thank you, Nancy. All right, so now we're talking about overcoming the barrier of hyperkalemia, treatment with potassium binders, and maintaining RAASi therapy in patients with heart failure. So Nancy just showed this slide, so I'm going to get right into it. What do you do when hyperkalemia develops? And there's a lot of bad answer choices on this slide right now. But the one I'm going to particularly talk about, because it's the one that is potentially the most problematic, is when we sacrifice the GDMT. We say, well, I can't have hyperkalemia and good GDMT. I have to pick one. And we sacrifice the GDMT for the sake of normokalemia. But the good news is we don't need to think like that anymore, and that in 2026, we have multiple tools in our toolkit to manage hyperkalemia and heart failure. And One way to think about hyperkalemia management is just with our good old-fashioned guideline-directed medical therapy. These are the therapies we already should be using for lowering mortality, decreasing the risk of hospitalization, but we now have data that SGLT2 inhibitors, on top of their other clinical benefits, decrease the risk of hyperkalemia. Isn't that convenient? And we also have data with sacubitril/valsartan that it decreases the risk of hyperkalemia with an MRA as compared with an ACE inhibitor. So doing the right thing for GDMT has these other accessory benefits in hyperkalemia. But we're also going to be talking about novel potassium binders. So when SGLT2 inhibitors and ARNI aren't enough hyperkalemia protection, we know that two novel potassium binders, are able to treat active hyperkalemia and also decrease the risk of recurrent hyperkalemia. And they're also able to allow you to titrate our GDMTs and maintain normokalemia while you're really pushing the doses of those good GDMTs. But just to talk about our GDMTs a little bit more specifically before we shift gears to potassium binders. So I mentioned SGLT2 inhibitors decrease risk of hyperkalemia. We've seen this time in, time out in a lot of the cardiovascular and kidney outcome trials. These are data on the left-hand side. These are data from empagliflozin trials in HFrEF and HFpEF put together. You see about an 18% lower risk of hyperkalemia or initiation of potassium binders among the patients randomized to empagliflozin versus placebo. And then you say, well, that relative benefit, 18%, that sounds okay. But what about the people that are on MRA, the people who need the hyperkalemia protection the most? Well, here you see in DAPA-HF, for example, 50% lower chance of developing a potassium above 6 among patients on MRA who are randomized to dapagliflozin. So again, seems to have a really heightened benefit for the people who need the most hyperkalemia protection at all. But I'm talking about here on the last slide about serum potassium values and hyperkalemia events, and yes, those are very important. But what we really also care about is MRA discontinuation. When we look at all our GDMTs for HFrEF, for example, of all the GDMTs that needs the most help for implementation, it's MRA. Well, the good news is SGLT2 inhibitors and ARNI help out their good friend MRA. So on the left-hand side, these are data from EMPEROR Reduced. Among the patients who are on MRA at baseline, randomizing the patient to empagliflozin decreases the risk of MRA discontinuation by 22%. Same story when we look at PARADIGM-HF with sacubitril/valsartan compared to enalapril. Sacubitril/valsartan decreased the risk of MRA discontinuation. So I already talked about how we need to use our GDMTs quick. When you delay, you expose your patient to needless excess clinical risk of death and hospitalization. But to put another way, when you delay initiation of an SGLT2 inhibitor, or you delay that switch from an ACE inhibitor to an ARNI, what you're also doing is needlessly exposing your patient to excess risk of hyperkalemia and excess risk of MRA discontinuation. Just another reason why we need to use prompt GDMT for our patients with heart failure. But now let's also talk about our novel potassium binders. And the two that I'm going to speak to are patiromer and sodium zirconium cyclosilicate, also called SZC. So first with patiromer. So patiromer is indicated for the treatment of hyperkalemia, and the mechanism of action is that it's nonspecific cation binding in exchange with calcium. So it exchanges calcium for potassium to get potassium out of the system, out of the bloodstream. Onset of action is about 4 to 7 hours after the first dose. We have good data for the use of patiromer chronically, upwards of at least 1 year, and it works primarily in the distal colon. Now, clinical side effects that you might have to watch out for with this, it does tend to lower magnesium levels. There can be some GI side effects of this therapy, and you do need to keep it in a refrigerator when you're storing it. And the other practical thing is that we tell people to avoid taking their other medicines right when you're taking patiromer. The guidance here is going to say try to separate it out by at least 3 hours so you don't sacrifice absorption of your other therapies. Well, what are the data we have for use of patiromer in our patients with heart failure? And it comes primarily from the DIAMOND trial. Now, the DIAMOND trial were patients with heart failure with reduced ejection fraction, and it enrolled really two different phenotypes. One was you had hyperkalemia on RAASi therapy, or you were normokalemic but had a history of hyperkalemia that required you to sacrifice RAASi therapy. Put those two patients' populations together, either actively hyperkalemic or at high risk of hyperkalemia, and they started the DIAMOND trial. Now, DIAMOND initially started with a run-in phase. And the way a run-in phase was, it was open label, and everyone got patiromer up to 3 times a day, but the goal was to really ramp up the RAASi and get the potassium in check as well. Doing this in the open label run-in phase of DIAMOND, 85% of patients approximately were able to achieve the dual goal of being on good dose of RAASi therapy, including MRA, and being normokalemic. So that's the first take-home point, is that 85% of these patients who we normally would just throw away the MRA, if you used patiromer, were able to ramp up the MRA and RAASi therapy to good doses. But then the people who were able to get up to target doses or near target doses of RAASi and maintain normokalemia, they were then randomized 1-to-1 to either patiromer withdrawal or patiromer continuation. And that was the double-blind phase of the trial. So these are some of the key results from the DIAMOND trial. Continuation on patiromer decreased the risk of hyperkalemia by about 37%. So again, patiromer offered continued protection from hyperkalemia events. But again, it wasn't just about hyperkalemia events. We also clinically care a lot about our persistence of MRA therapy. And here we also saw that continuation of people on patiromer decreased the risk of MRA discontinuation by 38%. Looking at safety, so patiromer was overall very safe and well tolerated as compared to placebo. You look at the total adverse events leading to discontinuation of the therapy, pretty much very similar compared to placebo. There was, even in this trial, actually no increased risk of hypomagnesemia actually as well. A little bit more diarrhea, a little bit more constipation, but overall safe and well tolerated, generally speaking. So now let's talk about our other novel potassium binder, and that is SZC. So this, instead of calcium exchange like patiromer, here we're exchanging potassium for sodium and hydrogen. Also, where the onset of action was about 3 to 7 hours for patiromer, SZC actually has a slightly quicker onset of action, upwards of about an hour or so, where you can start seeing the first effect. Also, we'll say, as compared to patiromer, where it primarily works in the colon, here we're having an effect in the GI system, again, throughout the GI tract. And here, in terms of adverse effects, the one I will highlight is there can be an increased risk of edema, and that's something to look out for as compared to patiromer. So just like patiromer had the DIAMOND trial, SZC has its own trial in heart failure patients, and this was the RAASis trial. And generally similar study design compared with DIAMOND, a couple different nuances to it. But again, it's similarly heart failure with reduced ejection fraction. They were on optimal GDMT at baseline except for MRA therapy, and all patients were either had active hyperkalemia at baseline or were normokalemic but had high risk of hyperkalemia, and that required, that's why they weren't on good MRA. Similar to DIAMOND, the patients then proceeded with an open label run-in phase where the goal was to maintain that dual goal of getting them ramped up on RAASi and MRA dosing while maintaining normokalemia. And then among patients who could achieve that dual goal, then they were randomized to SZC continuation versus withdrawal of SZC. So to speak a little bit about that open label run-in phase, because this is such a key part of these types of trials. So again, patients could get into the trial either by being actively hyperkalemic on RAASi therapy and MRA, or at high risk of hyperkalemia and prior had to discontinue or down-titrate their MRA. But needless to say, it made no difference in your ability to use SZC to get to your dual goal of normal potassium target dose of MRA therapy. Upwards of about 77% were able to get to good MRA doses while maintaining normokalemia. And again, made no difference whether you started off with active hyperkalemia and you used SCC to get you down with your potassium levels, or you used it as essentially like prevention, essentially from maintaining normal, from getting into the hyperkalemic range. Okay, let's look now at the randomized phase of RAAS-K, the primary endpoint. So the primary endpoint was achievement of normokalemia while being on at least spironolactone 25 milligrams a day and without the need for any of those rescue therapies that Nancy showed earlier for acute hyperkalemia. So for that primary endpoint, maintaining SCC gave you a more than fourfold higher chance of achieving that primary endpoint compared to placebo. So it was highly successful in keeping people on MRA while having normokalemia. Then you look at some of the secondary and exploratory endpoints here. It also achieved the higher likelihood of being on any dose of spironolactone. Also, I'll talk about it decreased the time to first hyperkalemic episode by being on SCC, decreased the rate of discontinuation of spironolactone, and then it did not actually impact KCCQ, quality of life, or hard clinical endpoints, but I'll say this, that the trial was technically not powered for hard clinical endpoints. Looking at adverse events and serious adverse events, numerically very comparable to placebo. There was a higher rate of hypokalemia with this therapy, as you might expect. The other thing that I will highlight is although there was no difference in cardiovascular death, there was, again, an increased risk numerically of cardiac failure and peripheral edema. Perhaps this is related to the exchange of potassium for sodium. This was seen in some of the other studies with SCC looking at kidney patients. Again, really not confirmatory. The trial is not powered for this, but again, something to keep in mind when you're using this therapy is to watch out for edema. Now, there's lots of different algorithms out there for how to use these therapies, both GDMT and novel potassium binders for getting people on our best possible therapy for heart failure. This is just one algorithm that I published recently, and you consider it at your leisure. So to sum it all up, when we're thinking about management of hyperkalemia in heart failure in 2026, so the risk of hyperkalemia, both the real risk but also the perceived risk, our fear of hyperkalemia, this is a frequent barrier to the initiation and up-titration of RAAS and MRA therapy for heart failure. But the good news is that with contemporary tools, hyperkalemia can be safely prevented and managed without sacrificing GDMT. You don't need to pick one or the other. We can do both. And that's because we now know that we have SGLT2 inhibitors and ARNI instead of ACE to help us with our potassium management. And then when we get into trouble, we also know we have novel potassium binders to get us out of trouble if needed. I'll say that with novel potassium binders, you can consider both a proactive approach in high-risk patients. That's where you use them kind of upfront prophylactically among the patients you're worried about, and then you ramp up the MRA. Or you can use them as a reactive approach, and you just try the MRA again, and you use it if needed. But either way, I would argue strongly the mere existence of novel potassium binders should give us confidence to be aggressive with RAAS and MRA, and especially to re-challenge those patients who maybe were said, oh, they didn't tolerate MRA in the past. Well, now in 2026, with the tools we should have the confidence to re-challenge those patients, generally speaking. So with that, thank you very much for your attention.
Hey, everyone. While we get these slides pulled up, thank you for the opportunity to be able to share a case with you today. We're actually going to talk about what matters to all of us, which is a patient case. So we'll bring it home, talk about a case of managing potassium in a patient, managing a patient who has elevated potassium. This is my disclosure. I'd like you to meet Jim. Jim came off of an AI tool, but he looks like a nice guy, and he is coming to our clinic today to see us for management of his heart failure. Jim is 66 years old. He has a history of HFrEF. He's got an EF of 25%, secondary to an ischemic cardiomyopathy. He had a history of coronary disease. He has stage 3 chronic kidney disease and a diagnosis of type 2 diabetes. For his medications, Jim is on aspirin. He's on sacubitril valsartan at low dose, 24-26. He's on carvedilol, 25, spironolactone, 12.5, dapagliflozin, 10 milligrams, and then he's on torsemide, 10 milligrams, and atorvastatin, 20 milligrams QHS, probably like many in this room now. And so he's here for his clinical visit. He comes in at this time, he's euvolemic, he's routine seeing you in your follow-up clinic. But he's got class 2 symptoms. He's still intermittently getting dyspneic when he is walking stairs, which for him has been the case for a while. He misses his daily diuretic a few days per week, and that's strictly because he forgets to take it. It's not in a place that he remembers to take it, or he's quickly running out the door. When we asked Jim what his goal was today, and what you prepped as the clinician in advance was you pre-reviewed his medications and you realized that there were opportunities to optimize his GDMT. And so Jim leaves, we talked to him about his GDMT, and he leaves clinic and gets labs on the way out. So routine visit, right? Many of those 15-minute heart failure follow-up visits that you see are probably patients like Jim. Throughout this case, I'm going to stop and I'm actually going to prompt Dr. Albert and Dr. Green with a couple questions. But in somebody like Jim, you've pre-written your note. The nurses in clinic have probably already seen what your plan is. In somebody like him, without even knowing what his lab results are, and maybe Dr. Green, we can start with you, how would you sequence Jim's guideline-directed medical therapy to facilitate tolerability of mineralocorticoid antagonists in patients? And I'll bring up his med list again for you.
Yeah. Well, the bottom line, sequencing, that word gets used all the time in heart failure care, but I'm going to be a little provocative here. I think it's a little bit of a distraction. Sequencing doesn't matter if you do things quickly, and we have to do things quickly, because the default answer is we go too slow, one move at a time, I'll see you back in 3 or 6 months, and then things never get started, right? So the bottom line is we got to be aggressive. And just to cut to the chase, you look at he's on target dose carvedilol, he's on target dose of dapagliflozin, there's only one dose of that. He's not on target doses of sacubitril valsartan and spironolactone. So just keep it simple. What is he missing, and what do you need to do? And you need to be willing to, in my opinion, make more than one move at the same clinic visit. Now we're going to talk about, hyperkalemia risks here, and the 2 highlighted therapies, of course, can increase hyperkalemia. So, gosh, yes, I would want to know what his labs are, but do we dare ever try to do 2 moves that could impact hyperkalemia at the same time? Maybe, and probably we should, especially if we know we have novel potassium binders in our back pocket if we get into trouble, because they work really, really well.
Dr. Albert, do you have anything that you'd like to add to that question?
I would just say, especially in our patients that are fluid overloaded, these 2 drugs especially can help decrease volume. So if the patient comes in and they're still functional class 2 or heaven forbid 3 and higher, we really need to up-titrate their sacubitril valsartan and their spironolactone to get them on the target doses. And so I would not worry about the potassium up front. I would really try hard to get him on the right doses. Now, we haven't seen his potassium level yet, but especially in my patients, if their potassium is a 4.7 or less, I never hesitate to get them up, because even if they go up a little, the likelihood that they're going to go above 5.3 or 5.4 is pretty low. Now, of course, if they're in chronic renal, have chronic kidney disease, and their urinary albumin to creatinine ratio is in the one above 100, 150, 180, and moving uphill, I may be a little bit slower, but I would easily give both of these drugs. I would increase the doses at the same time.
That's great, and I think to take home that feedback about this slide is that it is really important that all of us recognize where there's opportunities and gaps in GDMT. As a clinic nurse doing intake and doing med reconciliation is just as important as the provider that's in the room that's prepping Jim for what to expect for next steps and the rationale about why we'd move quickly to intensify GDMT because we're not on target doses. letting him know that he got labs. And on the way out, his labs came back as follows. He had a sodium of 134. He had a potassium, surprisingly, we're in a hyperkalemia talk, so he's hyperkalemic, K of 5.8, up from 5.2 3 months prior. His creatinine is 1.4. He has a baseline creatinine of 1.3, however, and he's got a magnesium of 2. With the labs that you see presented, at what potassium level, and Steve, you mentioned this during your talk, what potassium level would you personally act, and how would you operationalize confirming hyperkalemia in the case of Jim? As a nurse, I think everything's hemolyzed, but I'd be curious to know what you think.
So the first thing is obvious is make sure it's not hemolyzed and all that kind of stuff, because then you have to take it with a grain of salt and repeat it and everything instead of freak out and throw everything in the garbage can. Above 5.5 I take seriously, but again, I think most people get nervous above 5, and I think one key take-home point is 5 to 5.5. I mean, there was just a publication in European Heart Journal too. Those people are at lower risk than the people with potassium less than 3.5. Like, we just bat an eye at, potassium at 3.3, no big deal, just start some potassium pill and I'll check in a couple. We don't have anxiety, but we get anxiety when someone has a potassium at 5.2 and 5.3 where we shouldn't. Now, the relevance of a 5.2 or 5.3 is, well, if you're not on MRA already, you can't start it at that level. You need to get it down so then you can start the therapy. But if you're already on therapy, like target doses, let's say, and you have potassium at 5.2 to 5.3, let it ride. Here we can't let it ride. 5.8, I'm going to try to get it down.
Dr. Albert?
And I'm concerned about the low serum sodium. So a low serum sodium like this is not an absolute hyponatremia. It's a relative hyponatremia, most likely, meaning that he's got too much water in his blood vessels, and so he's hypervolemic. So again, a really a good assessment needs to be done to see if he's holding on to water in his vascular system, let alone in his tissues. So, obviously he doesn't have PA monitoring catheter in or anything like that to find out, absolutely what's going on. So we need to do a really good assessment to find out what's going on. That's a pretty low serum sodium.
That's great. And this is nice because if you're in your clinic and you get this lab back quick enough and you're worried about that hyponatremia and volume status and you didn't have an NT-Pro added to your lab, you could add an NT-Pro if you needed to, or make sure that it's part of your order set so that you're evaluating those labs. In this case, we don't have an NT-Pro here for Jim, but important again, volume status as it contributes to your management plan. So for Jim, we actually rechecked his lab and it came back as 5.8. So the hyperkalemia was confirmed to be true. He was truly hyperkalemia. But how do we address it? We did talk briefly earlier about food consumption and diet contributions to hyperkalemia, but there's many other facets to risk of hyperkalemia, and Dr. Green and Albert did a really nice job of sharing those earlier. So important for us to recognize that Jim has chronic kidney disease. He also eats a diet that's pretty high in bananas. He has no interest in changing that. He wants to continue to consume his bananas as he has. But are there any other considerations for the group that you would have when reviewing foods or other supplements that are high in potassium that you've seen in patients that you've encountered in clinic? Dr. Albert or Dr. Green?
Do you want to go first?
I mean, bananas get all the press about potassium, but if you just Google what's in a potassium diet, which I will do in front of the patient, I'll put it in the discharge instructions too. A lot of things come up like oranges, kiwis, I think spinach. So unfortunately, a lot of like healthy things. But the thing is, though, I feel bad, giving all that kind of advice, like don't eat all these healthy foods and everything. And I'm also not really optimistic that it's going to make a meaningful difference either, to be honest, especially in a patient like this, because I got two problems. I got a potassium of 5.8 today, but I'm also, the second problem is I'm not on my target doses even. So I'm like I need to get normal kalemia on target doses. So the chances that, cutting out bananas is going to let me get all the way to that goal is low. So I'm already going to be quick to start thinking about, well, gosh, can I get this person on a potassium binder to get me out of trouble, but also give me the latitude to down the road, soon hopefully, get them ramped up on GDMT.
So I agree. I actually believe if the potassium is greater than 5.5, just telling somebody to change their diet's probably not good enough. It's going to come down maybe, a 0.2 to 3, and you're happy when it does that, but it's not going to drop possibly enough to make me happy, and especially in titrating the therapies we want to have up titrated, I'll not be able to make that happen. So when somebody has a potassium of 5.8, I wouldn't address it with just diet. That's when I really need to start having the discussion about potassium binders, why they're necessary, why we need to keep him on the medications he or she is on, in this case Jim. And also I try to talk to patients because a lot of our patients, at least in my neck of the woods, have other providers. They've got a hospitalist or a primary care doc, they may have a nephrologist, they may have other people they see, and the other providers are going to want to stop the life-saving therapy. So I actually say to them, if somebody tries to stop this medication while I'm doing something else here, I want you to call me and let me know. In this case, he had that really low sodium, he had hyponatremia, and so he needs to be diuresed, and giving him a nice little bolus of Lasix or whatever your favorite, I think he was only on 10 milligrams a day, or was that PRN even?
He was on 10 milligrams a day, and he is only
So that's
taking
like
it
a drop.
5 days a week, not
And he was forgetting
7.
to use it half the time, right? So, he needs to have some diuresis, and then we very quickly need to get that diuresis to happen, get his potassium down a little, and then start talking about the next steps.
That's fantastic, and that's exactly what we did in this case. So we diuresed Jim a little bit more aggressively, and we documented in the chart our discussion about why we didn't change his diet, to try to encourage other providers to read that note and not push that change. Instinctively, as nurses, we love to do something that's within our scope, so suggesting diet changes may be something that comes up quite regularly, but in Jim's case, we did we doubled the dose of torsemide, encouraged daily torsemide, but what we did was some shared decision-making with Jim. And Jim is like many of the patients that we've probably encountered, and his potassium, of course, needed to be addressed. And we really wanted to be able to push the mineralocorticoid antagonist up. And so in Jim's case, we discussed prescribing SZC. We prescribed 10 milligrams 3 times a day for 2 days, and then we reduced to 10 milligrams daily. We repeated the potassium in 48 hours. Jim was able to get back to the lab. He was reliable. We knew that he would follow up with getting a lab. And he actually chose to just eliminate bananas because he went on ChatGPT, and ChatGPT told him that you should really stop bananas, even though we said, Jim, you probably can eat them. But Jim had questions for us, and actually, not to be a spoiler alert, but we had a nice conversation last night with a small group, and actually a patient with heart failure who said, my cardiologist took me off of spironolactone because I had a history of hyperkalemia. And now you're telling me that there might be something that I can do. What do you tell me more about that? So in patients like Jim who have this question of a prior cardiologist told me I'm hyperkalemic, now you're prescribing a medication for me and I'm hyperkalemic, and you want to keep me on the medicine that's risky. How do you approach those conversations with Jim and follow up over the phone, which is where you're doing most of this follow-up, to encourage him to be on board with this plan? Dr. Albert, do you have suggestions for that?
I would say the first thing is, you have to have honest conversations. You need to really listen to the patients and what their desires are. But frequently what I do is I discuss the rationale for the medications that I know that can lead to hyperkalemia, and you've seen them here. And then I really explain the value of those medications, and by removing them or decreasing the dose, what the harms could be. And then I explain we have newer drugs today. They're not even that new anymore, I've got to say, but I say we've got newer drugs today that we could use to help maintain your current doses of the life-saving therapy. And most patients, when they really understand that over time, they're more likely to be on board. These drugs do have some caveats we need to talk to patients about, especially because you don't want them to take it too close in time to their life-saving medications, because it may end up coming out. It may be leaving the life-saving medications may not be fully into the bloodstream, so we have to pay attention. Each of the 2 drugs has some differences. with patrimer, you need 3 hours before and after your life-saving drug, where when you take the patrimer, you have to have 3 hours on each side. For SCC, it's 2 hours, so it's a little bit easier from that regard. But like Dr. Stephen Green just told us, you're more likely to have sodium being exchanged, and your patients may have some fluid overload. So you need to monitor patients, and they need to be on board with understanding what they need to watch for. So it's a long discussion. It's not a quick discussion. And I think nurses overall do have more time on their schedule. I see my physician's schedules, and every 10 to 15 minutes they're seeing another patient, where I have 45 minutes. So I can spend that time explaining what's going on. I don't know if everybody gets that amount of time, but I purposely tried to do that so that I can have these discussions with patients.
That's great. And in Jim's case, we were able to get him on the SCC and increase the spironolactone successfully, and his hyperkalemia came down, and he was well managed on these medications, because we're going to ignore the fact that we had to get prior authorizations and all of that. But that concludes the case presentation, and I'll pass it back over to Dr. Albert to moderate questions and answers.
All right, thank you.
Thank you.
Well, we have some questions here for people. Here's a nice one. Finerenone and hyperkalemia, how much is it, or what's the rate it's going to happen with finerenone, and how do SGLT2 inhibitors interact with finerenone?
All right, so from a hyperkalemia perspective, so the question is, well, we're used to hyperkalemia with our steroidal MRA, spironolactone, and eplerenone, but what about the newer kid on the block, finerenone? So the first thing I'll say is there's no real good head-to-head trials of spironolactone versus finerenone with adequate doses of both. There's some studies that have shown finerenone head-to-head with Spiro had lower hyperkalemia, but it was actually a low dose of finerenone, so I don't know if it was a fair fight. So the bottom line is there's no apples-to-apples direct comparisons out there, really, for very minimal. We don't know for sure if finerenone causes less hyperkalemia than the other drugs, but at least it seems to be trending in that right direction when you do kind of indirect comparisons. Finerenone still causes hyperkalemia, but the difference versus placebo isn't as much as you might see in some of the steroidal MRA trials. So it is what it is. You still have to be careful with finerenone and hyperkalemia, and the titration of finerenone is still reliant on checking potassium, and it informs, if you go up on the next dose, et cetera, if you hold the dose, et cetera, et cetera. SGLT2s, SGLT2s are a pillar for heart failure across the spectrum of ejection fraction. I would argue finerenone is a pillar for HFpEF. We got to use both for HFpEF. Again, plausibly, it makes sense that SGLT2 inhibitors would presumably decrease the risk of hyperkalemia with finerenone, but we don't really have direct, head-to-head trial. We don't really have direct data to support it in heart failure studies. In fine arts, statistically, it actually didn't decrease the risk of hyperkalemia with finerenone, the people that were already on an SGLT2 inhibitor. But again, we overall think SGLT2 inhibitors are a good thing for hyperkalemia, and you're supposed to use them anyway, so do it.
So that answers the other question about, do you have to worry about hyperkalemia with aldosterone synthase inhibitors? So yes, we do need to still worry about it, yeah. All right, the next question, what's your tolerance for hyperkalemia before sending somebody to the ED and first trying one of the 2 potassium binders? Does anybody have a thought about that?
I tried to avoid the emergency department at all costs. If a patient is seen in clinic in the ambulatory setting and has symptoms of hyperkalemia and had electric EKG changes with peaked T waves, then I would be concerned for arrhythmias associated with hyperkalemias if the levels were, above a certain threshold. But I don't actually now, thanks to working with Reverend Green, I don't get as worried about hyperkalemia as I did in the past. As a bedside nurse, it was my job to monitor that potassium, whether it be low or high, with an iron fist. But now, having worked in the ambulatory space, I think it's really opened my eyes that we can be more tolerant to hyperkalemia. Thoughts on that?
Yeah, So the situation that's going to happen is, you come in, patient's feeling fine, you get labs, they go home, and then like 2 hours later, you're about to go home too, and you're like, oh my God, their lab came back, it's like 6.3 or something like this, So the patient's asymptomatic, you didn't get an ECG and everything. I mean, in that situation, what I'm going to do is I'm going to call the patient and try to get him on a potassium binder right away. If not, I'm going to have him come back to clinic, hopefully, or have my nurse order KX-late or something. If it's actually repeated and I think it's real, assuming it's not hemolyzed or anything like that. But the take-home point, though, is less than 6, chill. Just chill. I'm not saying do nothing, but we don't need to have a panic attack over it, okay, when the potassium's 5.8. We have time, okay? We have time to have them come back and repeat it to make sure it's real before you just throw away all the GDMT. Then we can also keep working on potassium binders and all that kind of stuff. And then if it happens once, it's going to happen again probably. That's the other thing to keep in mind, right? So that's why doing through the legwork of making sure they have access to potassium binder is a good investment, because you're going to want to keep that potassium binder, whether you keep it on forever or you just take it as needed if these spikes happen. This patient declared himself is probably going to have an issue with hyperkalemia in a recurrent basis.
I actually had a slide that I took out because of time, and it showed recurrent hyperkalemia. It showed a group of 12,000 patients, and then the bunch that had hyperkalemia and what happened over time. And even out to many years, the hyperkalemia comes back for people that have chronic hyperkalemia. I would only add to this comment about going to the ED is that remember that there are some differences between the two drugs, the Patramir and the SCZ. And the SCZ is considered both acute and chronic because its mechanism of action occurs in one hour. Patramir, it takes 4 to 7 hours. So if somebody has a really high level, you're seeing changes on EKG, you're really worried about your patient, you could order this drug, and within 1 hour, the potassium is going to start to drop. So you don't really need to send them to the emergency room. Patramir is a drug that you don't want to use in acute scenarios. You could use both of them in chronic heart failure, but Patramir is more a chronic drug, not the acute drug. So we do have one of the two drugs that can be used acutely, and that would be a good reason not to send somebody to the ER if you really don't think they need to go. Do we have any other questions? Anybody want to come to the microphone with questions? All right, we only have a couple of minutes left here, so I'm looking at my clock. If anybody has any questions, you're welcome to come up to the podium here, and thank you so much for your attention today.